Hello there. A very warm welcome to you to panel number one.
Good morning, please.
Hello there, Samuel. Please turn your camera on if it is not.
I am trying to turn my camera on, then they're asking me that, oh, maybe, let me see now. Oh,
Maybe.
Yeah.
There we are. That's you, Samuel. And hi, Joy. There's
Hello.
you coming on as well. That's great to see you. Hi, Sam.
hi.
So here we are, panel one. Peter Yarrow will be joining us soon. And but I thought we should get going so that we did not lose time. It gives me real pleasure to welcome you, Samuel, and you, Joy, and thank you so much for coming on today to be with us. So this is a panel which essentially is about community mental health in rural areas, particularly rural communities. We're going to cover a number of different issues, of course. Scaling up might be one of them, and there will be many others. But what I thought we'd do is just invite you to jump in one after the other and introduce yourselves, of course, and explain a little bit about your organization, what you do, and especially emphasizing perhaps the model that you work with. That would be particularly useful. And then we'll have another go round and have some discussion. Hopefully by then Peter will have joined us. Samuel, do you want to jump in first?
Yes, thank you, Chris. Thank you, every listeners for this webinar, and thank you, Joy, of course. My name is Samuel Habimana. I am a co-founder and executive director of Rwanda Resilience and Grounding Organization. I am as well a PhD candidate at Loma Linda University in California, where I am here now currently. So my organization, Rwanda Resilience and Grounding Organization, is a non-profit organization that is operating in Rwanda around 9 years of working. We are operating over 15 districts of Rwanda. In that period, we are around helping the 3,758 people, which including genocide survivors, genocide perpetrators, the students, healthcare providers, community health workers, family with the children with the disabilities. All those people that we save, we have the mission to introduce to them awareness skills that contributing to healing their mental health problems and building their resilience. The intervention that we are using, it's called community resilience model. Community resilience model, and it is not psychotherapy, but it is a awareness model that's help the individuals to build their resilience. So maybe I will let Joy talk. We'll have much time to discuss on this. Thank you.
Okay, that's great. But it would be very important for us to know a little bit more about the CRM when we come back to talking. Joy, very warm welcome to you. Lovely to see you. And please jump in now.
Wonderful. So nice to be here with everybody, and giant thanks to everyone who's taking some time out of their day to kind of join this discussion. So my name is Joy, and I am the co-founder, along with Anita Kaslin, of the mental health organization Vida Plena. And I myself am from the US, but I live and work in Ecuador, and that is where Vida Plena is based. And so our mission is to build strong mental health in Latin America. And the way we do that is by focusing on treating people with depression and anxiety, specifically people from low-income populations, marginalized communities who would otherwise have no access to mental health care. sometimes strikes people as surprising, but Ecuador was listed by a Gallup poll as one of the top worst countries in the world in terms of mental health. And so that's what we're focusing on. And we do that through a model of therapy, which is called interpersonal group therapy. And it consists of people meeting together, groups of about 8 people over the course of 2 months, to be able to talk through some of the causes and solutions for their depression. And a unique aspect of the model that we're using is the groups are led by trained lay community members. So these are people who've been trained in how to facilitate the groups, how to apply interpersonal therapy. And we're using that. This is a model that's been used around the world and to great results. And so we're the first organization to be able to implement that in Latin America. There's a number of great organizations who are doing that across sub-Saharan Africa, the Middle East. And so we're really excited that we're replicating their 15, 20 years of success to be able to bring that model to people in Latin America.
You're muted, Chris.
What a mistake to make on a conference like this. So thank you so much, Joy. I heard that, and that's fantastic. Samuel, just give us another word on the model for the model that you use before we jump into the main conversation, because I'd just like a little bit more detail.
Okay, thank you, Chris. The model we use, as I said, it's a community resilience model. It's a model that has been started by an organization called Trauma Resource Institute with Ellen Miller-Klasser and Mike Sapper. That model, it's awareness of skills of a set of 6 skills that is helping individuals to, it can used by individual or it can be used with the community. So when we, that model, community resilience model or CREM, it has been used in many different countries here in the United States, in Rwanda, in Sierra Leone, in Angola, in Kenya, in Nepal, in many different countries. That model, it teaches the individuals to have the ability to track, to know himself, and teaches him or her to have the ability to move forward, to overcome with mental health stress and move forward to awareness skills. It is a biological-based intervention. So we have been adapting this intervention in Rwanda since 2015. And then when we use this intervention, we start seeing the impact of community resilience model to responding to the persistence effect. Some of you know that Rwanda has been experienced with a genocide. And after the genocide, there was a lot of mental health problems. So this community resilience model is one of the intervention that is operating in Rwanda in many different types of individuals to help them to not only healing mental health problems, but as well building a resilience, a reconciliation, and the forgiveness between survivors and perpetrators.
Thank you very much.
I'd hear a little bit more, Sam, actually, just about how that, oh, I see that Peter's joined us. We might give him a chance, but I'd love to hear more details, because that's something that in our work, we're also looking at building as Ecuador, Latin America, facing these sort of challenges. How does it actually work? What is the details of how that works? How do you teach these resilient skills?
Yeah, thank you, Joy. Normally, this community resilience model, we work with the local readers, and then they help us to get the people who will, because there is a lot of needs, a lot of people who need the intervention, but we work with the local readers to select the participant. And after that, we enroll them with 4 days of community resilience model trainings. It's a trainings. We train them. And as well, if the person wants individual training, we do that. But mostly because of a lot of needs, we enroll 20 to 25 people in a group with the 3 or 4 training CREM trainer we have been likely to be trained by that organization, Trauma Resource Institute, that have been starting the model, and I participate in different interventions, trainings. So those people, for like between a 3 and 4 guide or frame trainer, they train between 20 to 25 people between like, we use 3 days of intervention, and then we continue doing the follow-up. Thank you for asking, Joy.
Let me just jump in here and welcome you, Peter. Peter, it's very nice to have you with us. I know that you had a problem with your internet, and so here you are, and that's the most important thing. Peter, why don't you just jump in, introduce yourself and your organization, and give us a little feel for the kind of work that you do, the model that you use, and so on. And then we'll come back into the conversation. As you can see, we decided to start without you, which of course at one level is rude, but at another level means that we were not going to lose any time. And I'm sure you're happy about that. Peter, welcome.
Thank you very much, Chris, and colleagues, Joy and Samuel. Thank you for holding it whilst I struggle to join internet. For the past few days, we've had challenges with our internet, and I've had to use various ways to join. And I apologize to all other participants for coming in late. But I myself have been looking forward to this discussion and felt quite alarmed that I might miss. Mm-hmm. My name is Peter Badimak-Yaro, but I'm just known simply as Peter Yaro, and I work for Basic Needs Ghana. It's good Chris is here, because anytime he's there, it makes the work easy for me, because my journey in mental health started with him. He very much is the architect of the model for mental health and development, which has become a global model, and Basic Needs has championed and practicalized it in Ghana and some parts of West Africa at various points in time. So simply, this model for mental health and development is one that has really brought mental health into development practice, going beyond just medical considerations of mental health to situating it within development, within poverty reduction, within livelihoods, within rights to participate, and for inclusion, and addressing the social stigma associated with mental health conditions and people living with mental illness. And lastly, developing collaborations and partnerships that advance the mental health and well-being of persons living with mental health conditions or affected by the mental health conditions of their relatives and friends. So simply, the model for mental health and development is one that is a rights-based, people-centered, particularly user-inclusive approach to addressing health and socioeconomic needs of people, focusing on strengthening health and community systems, driving economic empowerment and rights, and maximizing community resources to improve upon access to quality essential healthcare services that is within the proximity of communities and people. So by way of introduction, let me just end here and say Basic Needs has been Basic Needs Ghana, which evolved from Basic Needs Trust that Chris set up and brought to Ghana to start with, has been operating for the past 20 years now. We have reached close to 2 million people and still counting. And thank you for the opportunity to share with you. Over for now. Thank you, Chris.
Thanks, Peter. And of course, it's lovely to share the screen with you at this time. Joy, if we could come back to you, please. Are you thinking of scaling up your work? Because I know at the moment you're based mostly in Quito, in the capital of Ecuador. And that's where the model that you're using has been obviously practiced and piloted and practiced and so on. But I have a feeling that you may be wanting to scale up. Am I right?
Yeah, it's so exciting to be kind of part of this group, and especially getting to talk with somebody like Peter, who has like experience kind of building such a big program. So Vita Plena, we're in our second year. We just started over a year ago. And exactly, we are in kind of an exciting moment where, so to start with, we trained, just to get a sense of the scale, we trained 10 people as community facilitators, group facilitators, and they are working for us. We pay a small stipend position in which some people are working more or less full-time, some people are working very, very part-time, few hours a week. And so they run differing amounts of groups. And the goal for this year is we are absolutely planning on scaling to a second geographic location. And part of the reason for that is to be able to kind of just see the differences working in an urban versus rural environment. And so Quito is, in global terms, not a huge city, but it's about 2 million. It's very urban in sort of the setting. And so this summer, we are expanding to a second area that's more, like I said, more rural, agricultural, and then also has a very large indigenous Quechua population, which will be an interesting kind of like mix from where we have been working, which is largely with would be considered in Spanish, like the mestizo population. And also part of that, a lot of like refugees from Venezuela and Colombia. And so that's definitely happening. And so it'd be interesting to hear. I'd love to hear from like both Peter and Sam about how have you worked in terms of scaling? So we have two thoughts around how we think about scaling. One is building vertically and hiring more facilitators who are on staff with us. We train them, we monitor their work very directly. And then we're also in the process of developing partnerships with two local government organizations. One would be Municipality of Quito, other would be in the state of Imbabura, and training people on their staff to carry out the model. And we would help train them and kind of supervise them, and then they would kind of continue on. So it would be more of a sort of a trainer model rather than a direct implementation model. And so we're excited, year two, we're still a bit in the experimental phase of figuring out what works best for our local context. But it'd really be interesting to hear from both of you how you have thought about scaling and how that's worked. But yeah, so this is what we're in this process. And so last year we treated just under 500 people. When I say we worked with about 1,000, but I say treated as people who have moved from having moderately severe depression to mild to no depression symptoms. And we track that very carefully using what's called the Patient Health Questionnaire 9, the PHQ-9 is pretty universal. And so we track that very carefully every single week. Over the course of the 8 weeks, people are filling out their depression symptoms so we can monitor that, both for the person to better know how they're feeling and be able to feel their own changes. And then also as a program, one of our fundamental principles is evidence-based work. And so for that reason, we're using this proven model, and then we're very carefully applying it. So as we think about scaling, one of the things I'd be curious to hear again, like how you've gone about scaling, and also the challenges of like, if we go with the model of like more partnerships, how do you maintain, you could say like, how do you maintain control? Like, it's kind of that sense of like, when it's our people, we can be sure they're doing it right. We can be very carefully, like meeting with them weekly, checking in, and have a little bit more like power to be able to say like, actually, you're not applying the therapy the right way. We need it this way. And we need these data points collected. Whereas when we're working through a government partner, we lose some of that. You could say some of that. And so curious to hear it both of you. How have you been approaching that model?
Yes, the whole question of managing quality, as it were, as you scale up is always one of the things that gives people anxiety as they go through that journey. Sam, what have you done about this so far?
Thank you, Grace and Joy. So what do we do in terms of scaling? Initially, when we start using Cómo in Rwanda, we start on the people who have a lot of mental health problems, the genocide survivors. And then we rigorously do the quasi-experimental research. We have already published even that paper of how community resilience model has impacting the genocide survivors. And then when we see that intervention is working on genocide survivors, we start scaling up to even genocide perpetrators. So as Joy, you say, it's when you are scaling the intervention, it's always we were thinking about the geographical location, and as well we're thinking about the people that you are going to to train. Of course, the challenge is we always want to keep vigorously evaluating the impact of the intervention, and as well keep tracking whether what the people, for instance, we trained the community resilience model for healthcare providers. We will tracking that if the healthcare providers that we are scaling community resilience model are keeping using the community resilience model. Otherwise, we can scaling and the people adapting in their own way. At the end, they use another things which is called the community resilience model, which is not, and even the outcome, it can become different. So what do? We train them, and then we keep giving them refresher training, and as well work close with the Trauma Resource Institute, with the Madame Ellen Miracrasa and others CREM team, so that we can keep updating each other, so that we can keep the originality and the nature of the intervention.
Would I be right in saying, Sam, that one of the things that's interesting about the CRM is that each individual is taught the model effectively, and then in a sense, the degree to which they apply it to themselves and to others is a sort of self-correcting thing in a sense, so that takes care of some of the issues of quality, although of course you still bring in outside training and support as you go along. Yeah, I can see that. Peter, I think we are interested to know how you managed to get up to 2 million people over the period of time that you've been working in Ghana, and of course it's quite a long time now, 20 years. It's a big number over the years, and so scaling has obviously been part of Basic Needs Ghana for some time. It's something that you've done a lot of, both programmatically and geographically and so on. How do you see scaling, first of all? What's the sort of basics that you bring to the table here?
Yeah, thanks. Scaling, as has already been mentioned, has various dimensions. For us, our scale has been over the period of years that we've been working. So in that sense, incrementally from 2002, as we build on, from one project to over 22 of them between 3 and 5 years, is one aspect of the scale up. But the other is the replication by other partners and interested agencies, including government agencies that have applied our model, if not in its entirety, but in various aspects of it, particularly the aspects around community-based mental health care, ensuring that it is within the primary care level, the basic community health service that can be provided to anybody for basic essential services. Then we have also the intentional drive through our strategic plans to grow to new areas, including communities, regions of the country that we have not been in because of the success of the model. But let me also hasten to add the other dimension of the model being an ever evolving and dynamic one. And now, over the last 2 years, the model for mental health and development has evolved to focus on psychosocial support, human rights that were there, now more in the fore, systems strengthening and being recovery-oriented and building resilience. And that's where the good old model for building self-help support groups to also expand by reaching out to more people who need services come in. So through the self-help support groups, peer supporters or peers of the self-help groups also take up the mission, if I could say so, to reach out for the unreached but who need services. So there are multi dimensions to our scale up, from one, benefiting for the number of years of implementation of projects, an intentional drive to go to newer grants, virgin areas, and replicate the model, and building other capacities of other agencies, that have been interested in the model. They may be in a women's group focused on women and gender issues, or they are farmer-led associations of youth-based groups, but who want to include mental health in their activities, have been the various dimensions that the model has taken by way of scale up. And so the numbers that I am talking about. Over.
Thank you. Thank you very much, Peter. Friends, we've got some questions coming in from the audience, which is great. And I wanted to just ask you a couple of these. Joy, there's a question coming in for you here, which is what's the time for cultural adaptation and validation of psychometric tools such as the PHQ-9? And then it goes on. Let me just bring it up. Then it goes on. And are you thinking of adapting the tool again for your work in the new rural area in Ecuador with a larger indigenous population? So put your mind around that, but not for too many minutes.
Yeah, so those are great questions.
They are.
And so obviously something very important always. In our first rendition, given that we were working with a largely mestizo population, the PHQ-9 had already been broadly validated in Latin America. And so we didn't create any sort of adaptations. As we were beginning this new rollout, we have partnered with a locally led indigenous organization, which to our great benefit is actually led by 4 Quechua psychologists. And so they are going to be helping us at least conduct some initial community outreach on how do these, like, we also use the GAD-7 for anxiety. We also have some questions around subjective well-being. How are these types of questions received and perceived in the local communities? And so potentially, and sometimes these we are also thinking about is beyond that. We have first level is that the test itself, the evaluation itself, is that appropriate? And then secondly, it's just very practical questions around how do we implement that? And so kind of like, for example, right now in Quito, a large portion of the people we work with have smartphones. And so we just literally in a WhatsApp chat, will text them the link for all of the evaluations that we want to conduct. And then the person will fill out those evaluations on their own. So that's like practical in terms of like saving staff time. And then as we think about like in a different region, if people don't have smartphone access, they don't have easy access to data and Wi-Fi. And then if there's lower levels of literacy, will that be a problem for people to be able to fill that on their own? So these are like the very kind of like practical sort of questions. There's kind of different levels. One is like theoretically, do these tests make sense? And then secondly, if practically, how do we apply them in a way that makes sense? So these are the ways we're kind of this. So I don't have like, we're still working it out. We're still working it out what those will exactly look like, but they're kind of like real world problems, what we're challenges that we're looking at.
Absolutely. No, that's great. Thank you very much for that. And Peter, there's a question here for you. Which I wanted to ask you. How, this is coming from the participants, the audience, how receptive are governments and healthcare providers to working with you as you scale? And what sort of challenges do you face?
Well, receiving your model or your work is based on evidence. That's the way I can put it. And also working with them right from the onset. And that is what Basic Needs as an organization and the model has sought to do. One, the model has been clear with regards rather influencing the existing public health system to be receptive and integrate mental health into general healthcare services without the need to create parallel structures that are well-resourced or are first class, but only supported because of external funding. Rather than doing that, it has been to work within the existing system to improve it so that accepting it or its reception will be virtually seamless. And that is also demonstrated by the results that emerge or that come from what we do. Always, every endeavor has its challenges. And I would say the first challenge had been that people, until now, I would say in recent times, because of the global groundswell, there is some sea of, or a wave of calls on governments to do something around mental health, particularly from the UN high-level meeting and WHO events. But before then, people were more interested in what they said. We are more concerned about communicable diseases. Malaria is still a challenge. We have issues of we have issues of cholera and the rest. Why bother us with mental health, which, if for anything at all, as somebody said, it doesn't kill. They are just a drain on our resources. But we were able to demonstrate from the work we do that not only is there a need for mental health care services, because many people are experiencing common conditions that impact on their day-to-day lives, but also demonstrating that simple steps mobilizing community resources and involving families in the treatment and management of mental health conditions does not require so much capital outlay. And I think providing that cost-effective, community-oriented, very easily adaptable, adaptable approach was convincing, and not much needed to be done. So issues of resources and initial resistance has been the challenge, but the biggest would be lack of political commitment, where even the health budget, as we all know, mental health is still a very small proportion of it. And we are hoping with time, budgetary allocations and investments in mental health would grow over.
And of course, we shouldn't forget the way in which mental health and death by suicide is associated. And that, of course, is also part of the argumentation for taking this matter very seriously. Samuel, we've had an interesting question come up from the audience, which I want to share with you and see what you think about it. It says, how can we help our community to understand the fundamental benefits about mental health? Because here in Guatemala, it's common to hear quotes, just crazy guys go to the psychologist, unquotes. In other words, there's this kind of question of stigma and disbelief in seeking support or treatment for it. Where do you lie on that? How do you deal with that in the Rwanda context?
Thank you, Chris. Thank you for that participant asking that question. It's obvious even in Rwanda, there is a lot of stigma around mental health and seeking mental health services for the people who need the mental health support. But the interesting things, the reason even more why we use a community resilience model, it is an adaptable intervention which is non-stigmatizing. In Rwanda, when the people think that they are going to go to neuropsychiatric hospitals, they are thinking that they are crazy, they are whatever. But when we teach them mental wellness skills, which is community resilience model, it's the model that they use in their own life and help them. In addition, mostly which is also needed, we do it's awareness, talking about mental health problems, so that the people can be, I can say, can be free, starting attending those community-based trainings, intervention, so that it can help them to lower, for instance, in a community resilience model, we have been using different psychometric tools like a PSM and emotional dysregulation scale. We've been using the anger scale, brief resilience scale. All those psychometric tools has been showing a decrease of mental health problems and increase of protective factors like resilience and reconciliation for those who attending the community resilience model in Rwanda. That's proof that at least it's something that people can use when we are in this processing for fighting against the stigma toward mental health problems.
Thank you very much, Sam. We've got about 10 minutes left, just a little bit under. And I wanted to make sure that we start to pull this conversation together a bit. We've had some very interesting questions come up on the chat, the Q&A, and you three panelists have been wonderful in not only responding to the questions, but giving us a very clear sense of where you are in your organizational and model development, and also where you want to be, where you're heading. It would be interesting, I think, to ask each of you to think about what the future looks like now for you. We've developed ideas here on this panel, which are mostly current in the context of scaling up. And we've obviously shared ideas which relate to quality and quality management. We've shared ideas which relate to effectively depth of, in other words, the quality of the model itself, the depth of it, and whether that in itself, if you improve that over time, and deepen that is in itself a kind of scaling up, even if it may not be the other kind, which is geographical. And so there are a number of different ways in which we can look at this. And of course, training often comes into play here. And the anxiety that you don't lose a control of the quality is also there. So there are a number of different issues which you've brought up and which I've clumsily summarized just now. But I was wondering, Joy, how you see the future for the organization and in particular for the model that you're so committed to.
Yeah, I agree. I mean, I definitely see what you've created with basic needs and what Peter's leading as kind of our role model of where we kind of want to be able to be and kind of extending outward. And so that's captured in our mission. Like I said, we're building strong mental health. The idea is in Latin America. So currently based, started in Ecuador, but very much looking to be able to expand geographically. The hope is we will be in the next couple of years across Ecuador, and then starting to look at neighboring countries of how can we fit in? What are the benefits? What's needed? It's also always wanted to be very careful to work with existing organizations and to be benefiting them and not just coming in assuming that we know, but like looking at, okay, what are the gaps and how can we help fit them? And that is very much how we think about that. And so part of that is like definitely partnering with key local organizations. And sort of, I think most people who are attending this have seen how adding mental health component to any sort of program is a way to supercharge it. And so if you're excited about economic empowerment of women, for example, or improving outcomes for HIV/AIDS patients, adding a mental health component just strengthens those outcomes. And so part of what we're looking at is like having obviously a very definite geographic expansion, but it's like, how can we build mental health as a key component into all of these other programs? And so we see that as being very much a part of what we're doing because it just feeds into each other. If you can improve someone's mental health, it'll improve their economic outcomes. And also if someone's economic outcomes, their financial situation improves, that'll improve their mental health as well. And so it really just becomes this reinforcing positive cycle. And so that's how we're thinking about it, building kind of key partnerships.
Mm-hmm. Thank you for that, Joy. So then that, of course, brings us on to the whole question of systems change and systems influencing, which of course is very important. What about the future for you, Sam? Where are you looking?
Thank you,
Apart
Craig.
from your PhD, of course, which we wish you luck on.
Yeah. I see community resilience model ourselves in Rwanda Resilience and Grounding Organization as maybe as Joy said, we need to extend. We have been doing a longitudinal study for community resilience model. We see how it is impacting on parents of survivors and perpetrators. We are thinking in the future, Rwandan future, who are the young generation. We are thinking how we can scaling this intervention in the people, young adult from 18 to 30, because many people whom we trained, for instance, 2015, all the survivors, I can say some of 8 of them have been old, have been died. So we are thinking how we can scaling the intervention in the young population. And as well, we are thinking how likely in East Africa, we have a lot of things which is ongoing, insecurity and whatever, which is worsening the mental health problems among those people from East Africa. We are thinking how we can partnering with the other organizations so that we can use community resilience model with the other intervention program. I can say last year we have been collaborating with the Rotary Club. We use a community resilience model and the laughter yoga. So because the laughter yoga was one of our partners, and then we combined with the community resilience model, and it's helped the peoples. And we have another examples where community resilience model they are using with the other programs. That's where we are aiming and thinking how we can extending in future geographically in East African communities, countries. Excellent. And within Rwandan community among the young adulthood. Yeah, thank you.
Thank you, Sam. Thank you. We are coming up to the end soon. I'm going to ask Peter just to tell us where he thinks his future is as far as the organization is concerned. Just to remind you that panel 2 is coming up as well. That's a fascinating panel with the Friendship Bench, Colors of Connection and Man Talks, again in this series on community mental health. Peter, jump in and give us a minute's worth of your thoughts. If you'd like to unmute, that would be helpful.
Sorry about that. Basically, it has come a long way. And what we have noticed ourselves is we've been too generalized, but there are specific population groups whose mental health and well-being need particular attention. And so we are beginning to focus and zero in on youth mental health of persons living with HIV/AIDS and other non-communicable conditions that are chronic and long-term in that sense. And we also are we are using the lessons from COVID-19 to focus on preparing for outbreaks that would impact on emotional and mental well-being of people and building the needed skills and competencies towards that. We continue to focus on systems strengthening because Ghana has fashioned a very interesting approach to really integrating mental health or bringing about community-based essential healthcare services, what they call the networks of practice, that is focusing on local level, community level healthcare services at the basic possible healthcare facility provision facility that can be there. So we want to contribute to all of this, ensuring that mental health is within the communities, the networks of practice, and focusing on specific population groups, as I just mentioned.
Thank
Over.
You. Thank you, Peter. So Joy, thank you so much for being with us today. Really appreciate it on behalf of Glasswing, USAID and Catalyst. Very much appreciate you being with us. Samuel as well. Thank you. Really appreciated. And thank you, Peter, for your contribution. The wisdom that we've generated in this panel today has been wonderful. And we all very much appreciate it. Thank you so much to the audience, the participants. There were a couple of questions that we were not able to get to, but I'm pleased to say that we have put the links in the webinar chat so that if you want to reach out to specific people, that's fine. Many thanks indeed, and look forward to seeing you again.
Thank you.
Thank you very much. Wonderful time.
Yeah.
Thank you for the opportunity. Thank you, Chris. And thank you for all the participants that have stayed through up to now. We are grateful.
Thank you.
Pleasure. Pleasure.